You are listening to the Horse Radio Network, part of the Equine Network family.
Hello, and welcome to this episode of the Daily Vet Life podcast, where we chat with equine veterinarians about the cases they've worked on in their clinics. I'm your host, Alex Beckstedt, Editorial Director of Equimanagement, and in this episode, I'm speaking with Dr. Alexander Daniel about some navicular cases that he has managed. The Daily Vet Life podcast is brought to you by Dechra. Dr. Daniel is a board-certified equine surgeon with extensive experience in sports medicine and advanced surgical procedures. A graduate of the Royal Veterinary College London in 2007, Dr. Daniel began his surgical residency in 2011 at Colorado State University, completing a dual surgical program and earning a master's degree. From 2015 to 2019, he served as staff surgeon at a leading equine hospital in Wellington, Florida, where he gained extensive experience managing complex cases. In 2019, Dr. Daniel founded Daniel Equine, focusing on providing specialized care for sport horses in South Florida. Known for his meticulous approach and commitment to advancing equine health, Dr. Daniel has authored multiple studies over the years. His dedication to excellence ensures that each case is approached with precision and care, making him a trusted professional in the field of equine sports medicine. Thank you, Dr. Daniel, for joining us today.
Thank you for having me. Thanks for the introduction.
Of course. So we asked you to be our guest this month because you have quite a bit of experience managing horses with navicular disease, or more accurately, podotrichlosis, which is a condition that frustrates owners, farriers, veterinarians. What makes this condition so challenging to manage?
It's definitely a challenging condition. I think it's the variety in the pathology within the hoof. I think they're all a little bit different. So you can't just look at a single case and do one thing and expect it to work every time. So that you have to evaluate them carefully, try to determine exactly what's going on. I mean, it's a problem that's been around longer than I've been a vet. I mean, I've been doing it almost 20 years, which feels like a long time. And it's a problem that's been around long before me. And it'll be unfortunately, a problem we deal with, for the foreseeable future. So, and it's something we all deal with these cases. So yeah, I think it's the nuances of each case that make it challenging.
Yeah, I know I've had multiple horses deal with it. So yeah, it's not going away.
Yeah.
I know you've documented several of your navicular cases that you've worked on. Can you walk us through one of those and kind of what your decision tree looks like, how you diagnose and treat those horses?
Yeah, for sure. So, and I think this is where the challenge comes in. You have to have, like you say, you have to have a blueprint for how you're going to manage or work up a case. So for me, that is, I think it's a relatively simple approach. Look at the horse standing and you look at the horse moving. And my eye sees irregularities and lamenesses best at a trot. I mean, most people would say the same thing, but some people do see lamenesses better at a different gait. So I look at the hoof, watch the horse move, determine if I think it's one leg or both legs that might be sore, and then pick up the hoof, evaluate the hoof integrity, look at the frog, look at the shoeing, and basically apply the hoof testers, see if I can determine exactly where the soreness is. In most, if not nearly all cases, we'll talk about a particular case, which is this. The ones I have at least to talk about today are quarter horses, because navicular issue is very prevalent within the quarter horse breed. So this is a particularly interesting case. It had a check ligament injury. And so this horse had been recovering from that after some intralesional PRP and was doing well. But during the rehab, this horse then comes out and is found to be quite lame, and it's looking actually like it's bilaterally forelimb lameness. This was a second opinion case, so we didn't actually treat the check ligament, but we met the horse during the rehab. And So it has AAEP grading. It has a 3 out of 5 right front lameness on the circle to the right. It's positive hoof testers over the heels and slightly lame on the left front and positive to the hoof testers over the other heels. Its foot hasn't got the most perfect conformation. It's got a long toe and slightly low heel, which is not ideal, as we come to find out. We did a palmar digital nerve block, and that resolved the one limb lameness and now switched it to the other leg. So now it's got a left front lameness, and that's very typical. So, starting to think now, okay, caudal heel pain, got a quarter horse with a palmar digital block that now switches lameness. You are starting to think navicular syndrome, and block the other heel, and now the horse basically moves soundly. So that's the workup. And I think that's really important. You really have to localize the pain. So now that we've localized it, the next step is nearly always radiographs, standard views. The ones that we are, for navicular, the ones that we're talking about are the skyline view, which is that palmar proximal, palmar distal oblique view, so down the back of the heels, and also that dorsoproximal palmar distal oblique view. So you put the foot in a Hickman block and you shoot across the front of the foot and look at the navicular bone from sort of orthogonal angles. So in this particular case, there is increased size of the vascular channels. And I think that navicular radiographs look different each time, but this one had that. Others have increased, I guess, sclerotic changes within the corticotrabecular sort of junction. Others have enthesiophytes, which is the bony changes attached to the collateral ligaments. And so we've essentially, for the most part, established this horse has navicular. It had an injury in its ligament, but it's now clearly also got navicular issues. So at this point, we kind of pause and go, okay, that's our diagnosis. Now we need to start to discuss some treatment options.
Calling all equine veterinarians. Are you tired of feeling like you're on an island when it comes to caring for your patients? Dechra Veterinary Products is here to bridge that gap. They understand the challenges you face. That's why they offer a comprehensive line of high-quality products like Zycosan and Osphos, and empower you to offer your patients cutting-edge therapies like ProVet APC. They're not just a supplier, though. Dechra provides ongoing training and support to help you stay ahead of the curve and deliver the best possible care. Visit www.dechra-us.com to discover how Dechra can be your partner in equine health.
Once I'm convinced I have the problem figured out, and I think that's, so if we're talking about challenge, I think that's where it becomes challenging in some of these cases, because I think the radiologist will say satisfaction of search. It's like, are you satisfied you've found the problem and that explains the lameness that you've been looking at? And so obviously x-rays are the most readily available diagnostic tool. Yes, an MRI would be fabulous in every case, but it's not practical in most cases. And it's not actually, I would say it's probably not necessary in most cases, but that's where I think we see cases that are challenging that may fail. They may have more pathology than what the x-ray leads. That's well established. There's soft tissues in that region that get blocked by the same block. So, and obviously the big one would be a deep digital flexor injury. We have an MRI scheduled for a horse today with this exact problem. So we're trying to figure out, with that MRI, what's going on with the horse. We obviously suspect a little bit of a navicular issue, but we also, in this case, are suspecting some soft tissue issues. So those are the challenging cases. This one that we're talking about today, the first step in the treatment discussion is make sure the hoof is well balanced. And they all need that. So long toe, low heel is not good for a navicular horse. Several reasons. It puts more pressure on the navicular bone, just sort of passively because of the position of the bones above it, but also actively the deep digital flexor tendon has more pull. So there's lots of old research, probably some new research that says if you elevate the heels, however you achieve that, whether it's shoeing, trimming, adding a wedge, that decreases the strain on the tendon. So they all get that. And as long as we sort of start there, I think we're on the right path. For me, the next recommendation is to administer bisphosphonate, to give them osphos. And that's the way I describe it to the clients is you have a horse with a clearly defined bone problem, and you have a drug that has a very well proven bone mechanism. So this drug this osphos, it targets abnormal bone cells, the osteoclasts within the bone, and it helps restore the normal homeostasis of that bone. It helps provide, and it's got clinical evidence of and research of providing both a reduction in lameness, possibly some alteration in the bone biomarkers as well. But you have a drug it's FDA approved for that. So you have this, it's a singular drug, and it's an amazing drug for a case like this. And so I tell the clients, this is the first thing we should probably do. We should give them osphos. There are nuances that I do with osphos, which I think most people probably do, but perhaps shouldn't be assumed, is don't give them a non-steroidal drug right before you're giving osphos. Don't give it during the time you're giving osphos, and wait a few days after you've given osphos before you give them a non-steroidal butyramine Equiox. Just because both classes of drugs have effects on the kidneys, and so there are that, and that's been kind of well shown now that if you give them butyramine at the same time as you give them osphos, you may cause some issue with the kidney, at least in the short term. So the science behind osphos, at least, and I think probably what most people are seeing is like I said, it's this almost like it's the tomorrow drug. So you will see improvement in lameness over time. It can take a little bit of time before you start to see that. And in this horse, it was quite lame. So we opted we gave the osphos, we then came back and then did intrasynovial injections. And I say intrasynovial because and this horse we've been managing for many years now. So it started off with coffin joint, distal interphalangeal joint injections, which is, again, a fairly standard treatment. And over time, that became less effective. So we now do navicular bursa injections, which has been working very well. But the horse is administered osphos based on the fact that it's got these abnormal radiographs. The owner kind of gives the feedback at about 5 months after this has been happening now for years on this case. The owner gives feedback at about 5 months that the horse is starting to look uncomfortable again. And so we then repeat the administration of obviously a very in tune client, providing helpful feedback. And so the other therapies that this one is receiving are these, like I say, it now gets a navicular bursa injection every 9 months. So, and this horse went from, and it's sound. I mean, at this point, it's sound. So a 3 out of 5 bilateral 3 out of 5, at least one leg lameness, and with other limb lameness too. I mean, that's a very lame horse it's now comfortable. At this point, the horse is a 16-year-old quarter horse. So it's a great case. That's a sort of a poster child for why we would treat these horses, like I say, with osphos, and we being able to do other therapeutics, like we do a navicular bursa injection fairly routinely, just because of obviously our exposure to those kind of cases. We have fairly high experience with them now, so navicular bursa injection for us is relatively easy at this point.
Yeah, it's interesting. It seems like the bisphosphonates have kind of been a bit of a game changer as far as managing this issue. I had a mare back in 2015, 2016, shortly after these drugs even got FDA approval, who was diagnosed with some navicular changes. And yeah, we started her on osphos, and it was, every 6 to 8 months. That was what kept her going. And she's now 17, 18, and she's still doing the hunters. But it's interesting. I ended up selling her about a year or two after her navicular diagnosis, and when we disclosed to the buyer that this was part of her routine, she was going to need these injections, the bisphosphonates, on a regular basis for the rest of her career to keep her sound, and she was perfectly sound and performing well. It was kind of a red flag at the time. Like, she kind of balked a little bit about that. But have you kind of seen a change over the years? Because that was almost 10 years ago. And is it kind of a more accepted therapy for a lot of these sport horses?
I think, yeah. And apologies. What breed and sport again?
She was a warm blood, actually, and we did the hunters.
Yeah. Yeah, I think that has been something for sure that we've seen, definitely a change in the mindset between breeds. And it's, that's just over time, more of these cases, more availability of high field or even, low field MRIs, a better understanding of the problem. Yeah, I think that people generally now look at a warm blood in a much different light than 10 years ago. I mean, it's just, if you have a horse now that's a warm blood horse that has some of these changes, the horse may never know that they're there. I mean, I think that's very much true. Some of them have alteration in the bone shape and structure that just never causes a clinical issue. And I think obviously, they're probably even more receptive, I would think, than quarter horses are to therapy. I think that, at least obviously there's certain navicular cases that don't respond. I'm not saying all of them, but yeah, there's been definitely a shift in the mindset. I think this at least when I graduated vet school, navicular, well, these therapeutics weren't available. I mean, we didn't have bisphosphonates.
Right.
We had coffin. It was, if I go back, it was isoxaprine and shoeing, and that was when the science behind, shoeing was starting to change a little bit too. And then, we had coffin joint injections, and these were kind of the things that were recommended back then. So, it's changed a lot over the years. I mean, you still have to look at I think you have to look at each case, try to figure out the exact pathology that's going on. And I think that's probably, it's very easy to look at some of these and go, look at these x-rays and go, that's everything. And then and then not potentially find some of the other little issues that are going on. They're actually causing a clinical issue. So that's where they become challenging. That's when sometimes, the basic therapy, fails because yes, there is more going on.
Yeah, right. Well, it seems like these cases, depending on the underlying pathology, that some of these cases have become a little bit more manageable.
Yeah, very much so. At this point, have administered. I'm sure there are people that have given far more osphos and than I have, but I think at this point, I mean, I estimated about 400 or 500 doses that I've given to horses, which seems like quite a lot to me at least. We have a lot of these navicular cases with simple changes on their radiographs, like the sclerosis of the bone and or increased opacity of the corticotrabecular bone, which I guess I would say sclerosis, but and they respond to monotherapy, which again that's amazing that you have a drug that can do the work of what was historically a lot of, to do a lot of coffin joint injections to achieve soundness, and now you don't have to do a coffin joint injection at all. I think that's amazing. I mean, that's really good for the horse.
Well, we are about out of time, but I really appreciate you, Dr. Daniel, coming on and chatting with us about this very common condition that we're seeing every day.
Yeah, no, absolutely. Thank you for the invite. Yeah, I appreciate you guys for having me on.
Yeah. Well, thank you to Dechra for their support, and tune in next month.